Welcome back to The Explainer, everyone. I'm your host, Harshal, and today we're tackling a massive topic for medical coders and providers. Okay, let's dive into this. We are breaking down the major 2023 CPT guideline overhaul, specifically focusing on home or resident services. That covers CPT codes 99341 right on through 99350. Listen, if your practice involves treating patients literally anywhere outside of a traditional clinical office or hospital setting, you absolutely need to know these changes inside and out. So here's our roadmap for today. First, we'll look at the 2023 guideline overhaul. Then we'll map out the expanded location scope. After that, we're breaking down both the new and established patient code thresholds. Then we step into the danger zone with travel and prolonged services. And finally, you're definitely going to want to stick around for this part. We'll cover the top audit red flags that can literally save your practice's hard-earned revenue. All right, let's kick things off with our first topic, the 2023 guideline overhaul, which is all about simplification, but also brings some major deletions you need to watch out for. You see, the AMA fundamentally restructured EM codes to cut down on administrative burden. It's a massive consolidation that simplifies coding on the surface, but honestly, it's totally loaded with hidden traps if you aren't prepared. And this brilliantly illustrates exactly what I mean. Just look at this absolute graveyard of deleted legacy codes. If you're still relying on those old domiciliary, rest home, or custodial care codes spanning from 99324 all the way down to 99337, or even that specific home visit code 99343, you've got to scrub those from your cheat sheets immediately. They are gone, dead. Instead, we now have a beautifully streamlined solution, the 2023 codes 99341 through 99350, which basically wrap up all home or residence EM services into one neat package. But that brings up a really important question, leading us to our next section, the expanded location scope. Basically, what does home even mean anymore? Since all those separate domiciliary codes got axed, where exactly do we bill for these services now? Well, the AMA's new definition of a home is so much broader than it used to be. It essentially absorbed all those old, highly specific locations. Sure, it obviously includes a traditional private residence, but guess what? It also means treating a patient in temporary lodgings like a hotel or even a cruise ship. It explicitly covers assisted living facilities, group homes, as long as they aren't licensed as intermediate care facilities for folks with intellectual disabilities, and it covers custodial care facilities, plus residential substance abuse treatment centers. If your provider is stepping foot into any of these settings to treat a patient, boom, you are looking at the home or residence codes. Now that we know where we are, let's look at the actual codes, starting with new patient code thresholds, which are entirely driven by medical decision-making, or MDM, and time. But real quick, before we pull up the specific codes, let's not forget the golden 3-year rule. A new patient is someone who hasn't received professional services from your exact specialty and subspecialty within your group practice in the past 3 years. Make sense? Awesome. Now, here are the core mechanics. History and physical exams, they no longer drive your code selection, thank goodness. Instead, you're choosing based on either MDM or total time spent on the exact date of the encounter. For 99341, you need straightforward MDM or exactly 15 minutes. For 99342, you step up to low MDM or 30 minutes. Notice that gap in the numbers? Because 99343 was deleted, we skip right over it and jump straight to 99344 for moderate MDM or 60 minutes, and finally 99345 for high MDM or 75 minutes. Okay, let's move to and see how this builds when we flip over to the established patient code thresholds, looking once again at MDM or time. For your established patients, we're working with codes 99347 through 99350. Again, you're picking your code based on either MDM or total time. 99347 is for straightforward MDM or 20 minutes. 99348 is low or 30 minutes. 99349 steps up to moderate or 40 minutes, and topping it off is 99350 for high MDM or 60 minutes. Now, you really need to pay attention to the difference at these highest levels. Remember how a new patient high-level code required a full 75 minutes? Well, for an established patient, 99350 caps out at just 60 minutes. It's a huge distinction, so track those times very, very carefully. Tracking time brings us right into what I call the danger zone. Let's talk about travel and prolonged services. We've got the coding down, but how do we make sure we don't get penalized? This right here is where practices literally hemorrhage money. Take a look at this quote directly from the AMA guidelines. It says, when selecting code level using time, do not count any travel time. So the crucial point is this rule is completely unambiguous. sitting in bumper-to-bumper traffic, circling the block 10 times looking for parking, riding a painfully slow elevator up to the 12th floor. 0. None of that counts. Provider time spent in transit must absolutely never be counted toward the total E&M service time. Period. Your clock only starts ticking when you are actively engaging in clinical work for that specific patient on that specific date of service. But what happens when you're actively managing a patient at their home and you blow right past those maximum time thresholds? Let's say you end up spending 90 minutes with a new patient, which is well over the 75-minute minimum for that top-tier 99345 code. Well, that's exactly when you need to utilize prolonged services. If you're dealing with commercial payers that follow AMA rules, you're going to use the add-on CPT code 99417 for every additional 15 minutes of time. But listen up, a major trap here is mixing up your payer requirements. Medicare, for example, often flat-out refuses to recognize 99417. Instead, they require specific HCPCS codes, like G0318 specifically for home visits or G2212. You have to verify your specific payer's rules for prolonged services before you bill, or I guarantee you're going to face immediate, frustrating denials. And speaking of denials, let's wrap this up with the top audit red flags so you can focus on protecting your practice. I want to empower you right now with some direct, actionable compliance strategies. Now, what's really interesting about this slide is just how incredibly common these specific triggers are and how easily they'll spark an aggressive audit. Number 1, including driving or transit time in your time-based logs. We just hammered this point home. It is a massive compliance failure. Just don't do it. Number 2, misapplying that 3-year new patient rule. Listen, if your partner saw the same patient 2 years ago back in your main office, guess what? They are an established patient for your home visit today. Number 3, missing medical necessity. You absolutely must document the why. Why did this patient need to be seen at home instead of just coming into the outpatient clinic? If you don't explain that, you're toast. And number 4, reporting those deleted domiciliary codes. If your practice's EHR hasn't been properly updated and someone accidentally clicks 99324, it's an automatic rejection. So the big question is, are you ready to audit-proof your home services coding? The ultimate takeaway from today's explainer is the absolute necessity of exact, precise time tracking, completely excluding any travel, along with a total mastery of those expanded 2023 location definitions. If you respect the firm lines drawn around MDM and time, your practice is going to thrive, no doubt about it. But it kind of makes you wonder, with the AMA expanding what formally constitutes a home, how might telehealth guidelines start shifting to match this whole new reality? Well, we'll save that deep dive for next time. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.